Good day, ladies and gentlemen, and welcome to today's webinar, FSSA Update. All lines have been placed in a listen-only mode. You may submit a question during the webinar by typing it into the chat box on the lower left-hand side of your screen. We will be taking live questions at the end of today's presentation. All questions will be addressed at the end of today's call. If you should require assistance throughout the conference, please press *0 on your telephone keypad to reach a live operator. At this time, it is my pleasure to turn the floor over to Brian Tabor. Sir, the floor is yours.
Well, good afternoon, everyone, and thank you for joining for a very important presentation today. I was going to say announcement. I guess we are still in some ways in the announcement stage of the extension of the Healthy Indiana Plan waiver. Obviously, this is of significant import and great benefit to the citizens of Indiana to have this vital program extended for hundreds of thousands of Hoosiers. There are changes in this waiver. You've probably heard some about the work or community engagement requirements, maybe in the general press. But if you've been looking at some of our IHA updates and summaries, you'll know that there's quite a bit more to it as well with respect to expanded coverage for substance abuse treatment and some other important administrative changes. And I won't say any more about those because we have the experts with us here in the IHA conference room today. Dr. Jennifer Walthall, the Secretary of the Family Social Services Administration, is here with us to talk about the waiver. Many of you know Dr. Walthall, but for those of you that do not, she was the Deputy Health Commissioner at our Indiana State Department of Health, and before that, the Division Chief of Pediatric Emergency Medicine at the IU School of Medicine, and was an Associate Professor of Clinical Emergency Medicine and Pediatrics. Dr. Walthall has been a tremendous partner, and I know has worked very hard on this program, and we thank her for her efforts with respect to HIP and beyond. And so Dr. Walthall will lead it off, but I do also want to let you know that in joining us as well is Allison Taylor. Those IHA members know Allison. She has now been with FSSA since 2015, originally joined there as the General Counsel. And beginning in May 2017, she began serving as the Interim Medicaid Director and is now the permanent Medicaid Director of the Family Social Services Administration. She began her tenure there in 2017. Before that, she was an attorney with the firm Hall Render, Killian Heath, and Lyman, and served as Policy and Legislative Director for the Indiana Academy of Family Physicians, among other roles. Allison, thanks for being here as well. Thanks for all your work. With that, Dr. Walthall, I'll turn it over to you to introduce some of the new elements of the Healthy Indiana Plan.
Great. Well, thanks so much for having me today. It feels a little funny to be sitting in the room just kind of staring at my friends. So I'm going to pretend like I'm talking to you all in person. In fact, I gave a really fun webinar to covering kids and families on Friday over the same topic, and I was sitting in the Reagan Airport while giving that webinar, and I found myself gesturing wildly while I was talking to folks that I couldn't see, and nor could they see me, and got some great looks from folks walking through the airport as I was talking passionately about our new Healthy Indiana Plan. So for those of you who haven't said it out loud, I'll say it for you. Hip, hip, hooray. We are now full week into our approval, and the work has just begun. Really, the building over the last year of this application process and its subsequent amendments has been a true team effort, not just within the agency, but across agencies and then across stakeholder groups. And we've really enjoyed that process, and I think we have a product to be very proud of. And I'm going to walk you through some of the changes today, but before I do, they're really in three big buckets. The first bucket, and I think the most important, is our substance use disorder package that really puts us on par, if not ahead, of the way that the Healthy Indiana Plan delivers substance use disorder services in our time of crisis and beyond. The second is administrative reduction in burden for our members so that they can engage with our program in a more streamlined fashion. One of my professional New Year's resolutions was to make sure that our programs were not a full-time job. If we're going to ask folks to get a full-time job, we shouldn't be it. And so that really is the spirit of making sure that our programs are streamlined and really met to meet our members' needs. And then the third is really kind of the new, what makes this a demonstration waiver, which is trying something different. And that's the philosophy of connecting health insurance access to employment status. And as you'll hear, this really isn't my pet theory is that for the first few years of this really won't be much about employment. It will be more about getting ready for employment because, as we all know, most of our HIP members are already working. And because of that, how do we help get that next step better, next job up, getting ready to engage in employment for those who may not have thought that they were able to do that before, connecting those social determinants of health to individuals so that transportation barriers and childcare barriers and housing barriers are not the things that are keeping people from where they could be next in this really extraordinary climate in which we find ourselves economically and in the employment realm. So let me take a couple of steps back, but that's just kind of the overview of what we're going to talk through today. So first of all, when I think about healthcare reform, as we've thought about in the last year where we had this wonderful, crazy ride together thinking about what should healthcare reform look like, I think about the iron triangle. So it's, cost and access and quality, and how do we maximize access and maximize quality while at the same time decreasing the cost of healthcare. And the idea was, when we started this journey 10 years ago with HIP, was that we could start the conversation by increasing access, and once we figured that out, then we could move on to the harder things. Well, 10 years later, here we are, still talking about access. So can we maximize quality while containing costs, and is the answer to increase access? The preliminary information is that, yeah, it might be. Is as we decrease our uninsured rate, can we increase and improve health behaviors and health care outcomes that drive down costs and increase quality at the same time? But until we get past the access question, we really don't have enough energy or bandwidth to even start talking about the other two. So really the driver behind the Indiana Plan renewal was to continue down that path of increasing access to its maximum level for Hoosiers to meet their needs. So the brief history of HIP, as you all know, is HIP 1, which wasn't, of course, called HIP 1, but we'll cutely call it that now, was built under the Daniels administration, built on the cigarette tax. And so that expanded health coverage for about 40,000 individuals, and it was, when we ran out of cigarette tax money, that was the maximum number of folks that we could cover. And it was really a resounding success in increasing at a small level access. And so then under the next iteration, when healthcare reform came around and we had the option to become a Medicaid expansion program, we took the model of HIP 1 and then evolved it into HIP 2. So that continued with this partnership, this trifecta partnership with the federal government, the Hospital Association, and the same cigarette tax that had funded HIP 1 to expand coverage now exponentially to over 400,000 individuals. And the components that made the HIP expansion different than other expansion states were a couple of simple but really powerful premises. The first was, if we can engage members in their health care in a tangible way, maybe their behavior will change along with it. And so with that came the Power Account, which is a contribution to their health care plan. It's very similar to the private market to kind of be the training wheels with the idea that folks would be on HIP temporarily and then move off into other insurance vehicles for good reasons, and that we would help them learn and navigate that process. We also increased our reimbursement for HIP providers to the Medicare rate, and with that brought thousands of new providers into our Medicaid family and have much higher access, not just because I have got a card, but because there's also a doctor behind that card to be a provider. And then also allowed for our partners in managed care to provide incentives for behavior change to really encourage and sustain those behavior changes for the long run. So when we look into how did HIP do? How was HIP 2.0 successful? And we dove into our year 2 data not too long ago, and I'd like to just highlight a few things. First of all, when we look at the key indicators in our enrollment, there's a couple of things that are important. So almost half of the individuals in HIP are very low income, with an income below 22% of the federal poverty level. So HIP really was designed to be an expansion to provide coverage for individuals up to 138% of the federal poverty level. But folks have opted into HIP because of its expanded coverage, its preventive services, holistic look at health, even though they were not necessarily the ones that we were targeting to find this kind of coverage. And that's pretty neat. 65% of all of our enrollees, even those with very low income, are in HIP Plus, which means that they participate in the cost sharing. They contribute $1 a month or 2% of their income. And this is phenomenal because of what you'll see in a moment in those changes in health behaviors that are part of really HIP Plus. So our total enrollment is over 400,000 individuals and growing. If you look at our enrollment by age, these are really exciting numbers. I think about individuals from 20 to 29 as the walking immortal. These are folks that just don't really think about participating in healthcare as something that is mandatory in part of your life. And so the fact that we are enrolling 120,000 individuals in that 20 to 29 age group means that we're starting that thinking about my health behaviors, my health care engagement, that's going to persist through generations. We also know for kids, and you know I'm thinking about kids all the time, we know that kids' health behaviors are driven by their caregivers' health behaviors. And so if we're enrolling young moms and dads and caregivers, we know that their kids' healthcare outcomes are going to increase right alongside of theirs. We also, when we look at race and ethnicity, this really mirrors the state. So we're kind of mirroring our overall state population with our percentages. However, we know when we map this out that we've got some work to do to make sure that we're reaching out to our minority populations and we're covering them better. And we have some incredible partners and some strategies in this next round that I think are going to help us meet those goals that we've set for ourselves. By gender, again, we have a greater proportion of females. One of the main drivers for this is we are taking care of pregnant moms. And we know that Indiana covers just a little over half of births for the state. And so we provide, and that it's important for us to remember that we are the primary coverage for birth, and so that we expand our maternity care to reflect that need. This is going to be a big tool for us as we try to meet the governor's challenge to us to be the best in the Midwest by 2024 in infant mortality. HIP will be a big component, a big tool in that fight. Now here's the slide that I like to spend a lot of time on as a pat on the back for HIP being a tool for good, in that when we built HIP 2.0, our estimates, our actuaries estimated that we would cover just shy of 10% of individuals who are medically frail. So we would really be taking care of a lot of healthy people. So, well, if you're above 100% of the federal poverty level, you must not be terribly sick. And so we're just going to be bringing in a whole bunch of healthy people, and this is going to be pretty easy to do, and we can do healthcare prevention and all the rest. In the retrospect, it was double that. So we had almost 20% of folks in HIP 2.0 that were sick. And the moment they came in the door, they were extraordinarily expensive, and they needed coverage right now. So if you compare that side by side with traditional Medicaid, individuals that have Medicaid as their insurance package, if they're diagnosed with cancer, they already have Medicaid. Then they get coverage for cancer, and so they are engaged in that screening and all the rest that comes along with it. Our HIP members, when we started the program, were getting on HIP because they were diagnosed with cancer. And so their diagnoses were actually a little bit delayed. So we had a big group of people that we really did more than just cover healthy folks. We were covering folks that really needed our help right away in a comprehensive manner. And so the fact that we came across a whole new population of folks that needed some help is that we really rallied to that. And honestly, it was, as we got started, was more expensive than we thought because we were taking care of some sick folks. But as we get into maturity and we're covering people and we can really get into prevention, we're going to see, we may not see this number move, but we're going to see our costs decrease because we're getting ahead of it. So that's what I'd like to share with you here in just a few moments. We also are really doing a pretty good job of helping bring communities together with healthcare coverage as a priority. So getting the word out that if you as a third party, faith-based organization, family member, community practice, whatever that may be, if you would like to be a third-party contributor to payment, then you can do that. And so we're having employers cover power account contributions and not-for-profits as well. And so we're very pleased with that, and we think that some of the streamlined processes in our next round of HIP will actually make this even easier. Also near and dear to my heart is emergency department utilization. This is really extraordinary. So if you look at our ED utilization in our HIP Plus members, the number of claims that were deemed emergency, now we can argue about the details of this as long as you'd like, so if you'd like to come chat about this later, we can, but
discussion for another day.
Discussion for another day. However, if you just take this at face value and say the number of claims that were deemed actual emergencies for ED visits at 76%, that is better than the general population. And that's extraordinary. That means that folks are going to the ED when they need to, but it means that they also are having, because our health outcomes are improving, it means that they have the network and access to primary care and prevention that they need as well. So the ED is there for them when they need it, and they're using it appropriately. But then we've also put in the backfill services to keep people out of the ED if they don't need it. So making sure they can get to appointments, making sure that we have access in rural areas. So what a great start to getting the job done here. For preventive care, again, the walking immortals, I'd like to just point out to you that our males from 19 to 25, so please don't take offense to the fact that I target young men who don't like to go see the doctor and don't prioritize it, but we're almost 50% of 19 to 25-year-old males in HIP Plus received a preventive care service. That's pretty extraordinary. I'm going to kind of dive in very briefly into what HIP did for cancer care, because I think it highlights when we think about what our priorities are for the state, we're not just talking about just your general well check, get your urine tested and your blood pressure, but this is big deal stuff. This is highly complex cancer care screening and behavior change. And so what did HIP do for that in HIP 2.0? So a little bit of Medicaid, fee-for-service, and HIP cancer care side-by-sides. In the Healthy Indiana plan, we had about 6,000 members who had cancer in year 2. And if you look at the difference between the Healthy Indiana plan and our fee-for-service, you can see that our Healthy Indiana plan members cost more for cancer care. And again, this goes back to the fact that we, in this period of time, we're bringing individuals in at their time of diagnosis rather than them already being members and having their cancer caught earlier in the process. And so, again, if you want to get better outcomes, you have to pay for it on the front end in order to reap the benefit on the back end. So important things to look at here. If you look at breast cancer, at HIP side-by-side and fee-for-service, we're doing pretty well. In fact, our HIP members are beating our fee-for-service members in getting annual mammograms. So really important that we're driving health behaviors, and now we know where we need to target some of this outreach and fee-for-service to really engage in prevention screening. And we're really hitting our markers for after diagnosis, seeing specialists within 120 days in the HIP program. For prostate cancer, this is incredible. So if you look at primary care visits with a rectal exam included and a PSA test, HIP is knocking it out of the park. So again, looking at prevention, screening, and health behaviors in our providers as well, we're really doing well, and we've got to go replicate that in our other coverage models as well. Now, for colon cancer, we've got some work to do. Our members are getting full colonoscopies when they're supposed to. They're getting the right kind of treatment. But the colorectal screening rates, so really getting to that upstream prevention behavior, we've got some work to do around colorectal screening for both HIP and Medicaid proper. And then here's the point where we all need to rally together. Is the biggest driver for all of this is how are we doing in tobacco use? So our HIP members are smoking at a rate of 35%, and they're only getting medical assistance with smoking cessation at 36%. This is a multifactorial approach that needs to be taken to drive these numbers down. We have our marching orders on how to do that, and I hope that we see a public health approach, comprehensive public health approach to this, and using HIP as a vehicle to drive these numbers down for the future. As we drill down into these numbers, the ones that make me the most nervous for our long-term outcomes is our smoking rates in our HIP members who are pregnant. And those numbers are through the roof, and what a great population to really target our interventions to. For cervical cancer screenings, almost or more than double the number of HIP members are getting screening exams for cervical cancer as fee-for-service. We need to drive both of those numbers up, but we're seeing that, again, that health engagement in our HIP members is driving screening. And that's all about motivation, but it's also about having more providers and having them engaged with these members as a medical home. So what do we know? What do we know based on just this tiny dive into year 2 HIP? We know that increased access is increased opportunity for prevention, and we're seeing it at work. We're also seeing that at first it's expensive. If you haven't been paying for something before, when you start, it doesn't have immediate cost savings. Those are things that we have to let breathe and play themselves out before we see that immediate return. It doesn't mean that it's wrong. It actually means that it's working. And so we're very excited about watching this play out as HIP continues to mature. We also know that early detection equals, in the long haul, decreased costs. And so as we have these HIP members mature and our network mature, that cost savings will manifest itself over time. So moving forward, again, as we increase access, we hope to increase quality, and then that last driver is really what we're looking for, is to have our costs decrease. We want to increase and improve our health workforce. Because of this, we really want HIP to work for the provider community as well, engage Hoosiers in healthy behaviors, and then really seize our prevention opportunities as we have this data play out. So smoking cessation, HPV vaccinations, and colon cancer screening are really kind of 3 of our big drivers for looking at prevention that's going to see these numbers move across the state. So what happens now? What does 2018 and beyond look like? What do the next 3 years improve upon what we have and try some new things? Let's walk through those. As I said before, the one that I'm most excited about as the vehicle for change in our overall substance use disorder strategy is the 1115 waiver that's within HIP. Now, just to be very clear, the coolest thing about it is this is not a HIP-only program. This is across all of Medicaid. So when you talk about raising all the boats, this is the thing. So this piece of the 1115 waiver is across all of Medicaid. So we find ourselves being in the bucket of a good payer because we are taking the bits and pieces that we covered before and we're linking them together to really be a continuum of service for substance use disorder. So the treatment gaps are inpatient detox, residential treatment, recovery services, peer support services, all of these things that really look at focused case management. Those are in the covered entities in the new waiver, and that's already going. We also, and this is actually, it seems small, but it's really a big deal, is that we lifted the Medicaid restriction on IMD providers. So IMD is Institutes for Mental Disease, and those are the big hospitals that have more than 16 beds. In the past, those have been excluded from being Medicaid providers for services. And there was a good reason for that policy to go in place when it did, but it really swung the pendulum too far and excluded us from those providing comprehensive treatment to those individuals who actually need a little bit longer inpatient stay. And so really when I think about these folks, it's those that have dual diagnoses, so substance use disorder and another complex mental health issue that need more than a 3-day inpatient stay to kind of set them on the right path to recovery. They may need, a couple of weeks, sometimes 30 days, and we've never had that option before. And we really created our own vicious cycle of recidivism because we weren't providing the kind of personal services that folks needed to get their treatment met.
We have maybe a little bit of a snag. Nope, we lost it on here.
I got it. Okay.
Let's see. I think we operator. Are we still up and running?
Yes.
Okay. We just lost it maybe on Dr. Walfeld's computer. I think we can. We're going to do a quick switch here, and we should be back in business. Apologize for the interruption.
Okay, great. So let me show you just a little bit of a map of what happens the second we turn off the IND exclusion. Here are our existing addiction inpatient units and residential facilities for the state. And then you turn off the exclusion, and suddenly, do this correctly. Here are the services that we now have. And that's just our existing facilities that now aren't on the exclusion list. And so our coverage suddenly looks a lot better, and that's just one tiny piece of the 1115 waiver. So again, very excited about those services and their expansion that can really start happening today. So we're looking forward to approving these providers as Medicaid, as part of the Medicaid family, and providing services for individuals in these new locations. The next bucket that we talked about before is easing administration burdens for the member. The first is, and probably the most powerful, is that our power accounts, instead of being a 2% charge each month of the individual income, that actually may change over time, and those calculations make it difficult for the member to kind of keep track of what their payment might look like. We are now tiering those so that you will know for the year what your contribution will be every month. So if you are in the $1 tier, you can pay for your year and know that you'll have guaranteed coverage and the peace of mind of being able to plan ahead. It also makes it easier, as we talked about before, for those third-party contributions to pay ahead as well. So faith-based organizations, other family members who want to help with healthcare coverage can do that in an easier way. We also are establishing a HIP maternity category, and this is cute. The maternity category is mama, which is awesome. And what it allows is that individuals who are in HIP on maternity, that they stay in HIP for continuity of care, and they don't have to switch providers as they move back and forth between different programs. It also moves all of the process of being a HIP member onto the calendar year, so it looks just like what everyone else in the commercial market experiences around, doing annual enrollments each year at the same time as everyone else. We also are having expanded incentives within our managed care entities for members who meet their individual goals. We will align those member incentives with really the things that are challenging our HIP members currently. So smoking cessation, substance use disorder treatment, chronic disease management, and then our employment-related incentives as well. So their MCEs can really reward individuals who are really making positive steps forward in engaging in their health coverage and health care. Our tobacco use incentive is for HIP and all of our health plans. They will offer programs to help members quit using tobacco. And members who are smokers, self-attest to smoking, have 12 months of HIP coverage to stop their tobacco use. And at the end of that, we'll have a surcharge, which is 50% increase in their power account contribution for the next year, to help them in their struggle and help really increase that motivation to stop smoking. We also, in HIP Plus, are adding chiropractic coverage. This is really key as we think more creatively about non-opiate strategies to pain management. And so adding chiropractic benefits to the HIP Plus plan will help individuals who are struggling with chronic pain or other issues to have those services provided in a way that is an opiate-sparing process, where this is just the beginning of thinking about that a little bit differently. So we're excited to bring another group of providers into the HIP family. Our redetermination policy update as well is, again, moving into the kind of more consistent with our original HIP program. We are doing the redetermination process each year, and we'll have a 6-month wait for those who have not been able to comply with redetermination to re-enroll. Now, what we're trying to do in concert with this is make sure that this isn't happening to folks because they really know how the process works, and we've made it easier for them. And so individuals that are moving out of HIP are moving out of HIP into a different vehicle for health insurance. We also have a new health plan selection period that we went through this year. At the end of each year, HIP members can switch to another managed care entity if they need to for the following year. And the 4 plans that currently serve our Healthy Indiana Plan members are Anthem, CareSource, MedWise, and MHS. And we just went through the process to switch health plans just last couple of months. And individuals can then make sure that they are in charge of who's covering their health care needs. So, for example, if you have a member with HIP until March 31st with Anthem and they are reapproved, they will be reassigned to Anthem. But they will have the opportunity to reassign their health plan during the selection period from November to December of this coming year. Example 2 would be a member has HIP until the end of October with CareSource, and they reapply in March and select MedWise. That member will also be able to change their health plan during the selection period, again, in November, December of 2018. So HIP Maternity is really kind of exciting, and some of this will seem a little bit wonky, but it really is going to look great on the user end for those who are pregnant. So individuals who are pregnant at the time of application will be enrolled in HIP Maternity if they qualify based on their income. And those with incomes above 138% of the federal poverty level will be then enrolled in Hoosier HealthWise. So women who are enrolled in HIP at the time that they're pregnant will stay in HIP while they're pregnant and move into HIP Maternity. So there'll be just a seamless, streamlined process that they don't have to move to different coverage during their pregnancy. They can continue with their providers, and there will be no cost sharing for pregnant members. These pregnant moms will also receive enhanced benefits, again, as part of the tool to decrease our infant mortality. We know that about 60% of our infant mortality for the state is based on perinatal risk, and we know those risks are mitigated when we have early access to quality prenatal care. So all women who are presumptively eligible due to pregnancy will move to Hoosier HealthWise or HIP based on income when they're found to be eligible on their full application. So we're really excited about these enhanced services for our pregnant moms for the state. When a HIP member learns that they are pregnant, whether the HIP member tells our Division of Family Resources via self-attestation, or they tell their managed care entity through a self-attestation, or we find claims review of data, then it all funnels into HIP, and we start to enhance their services.
And Dr. Walpole, if I might just for a second, I just want to, as you kind of review some of these programmatic changes, I do want to recognize that some of them are the result of internal assessment, I think, of the program and working on streamlining. Others, I think, are the result of dialogue with advocates, with providers, with enrollees, and talking about essentially how to make the program better from an administrative standpoint. So these, some of these are not new wrinkles. They really are, I think, system improvements, particularly in this area, talking about the continuity of maternity care and income thresholds and so forth. So I just want to thank you and let you know that we appreciate all the stakeholder input that's been done, not just in development of this waiver, but really since the implementation of the program.
Absolutely, and I think that hopefully that will characterize really everything that we do. That we are only as good as the last criticism that we received, and so keeping that open dialogue and that open door allows us to be innovative, because really at the end of the day, the members that we serve, that's our constituents. And so everything that we can do to make that member experience better gets us to the point where we're really starting to see the needle move in health outcomes. And this is a great tool to do that. So we're going to skip through a couple of these slides just in the interest of time, but we'll make sure that these are all available to you as you look for these changes to go live. They're live now, so we're excited about bringing our moms on board for these programs. But the next slide talks about all of the additional benefits that come along with hip maternity that we're excited about. So vision, dental care, non-emergency transportation that gets individuals to their primary care appointments, their OB appointments, chiropractic. They're exempt, again, for cost sharing. And then also, we're expanding those benefits for 2 months postpartum because we really recognize that when the infant is delivered, that's not when the healthcare needs end. And so that gives a transition period for the new mom to get into the healthcare coverage that's going to last beyond just that immediate maternity period. This is really critical as we connect to the substance use disorder opiate epidemic because we have a rising number of moms with substance use disorder on HIP who are delivering infants with or at risk for neonatal abstinence syndrome, and that requires that coverage is seamless as moms are in this comprehensive care while pregnant. We can't drop that just because the infant has been delivered. Those ongoing services like counseling and medication-assisted treatment and the services needed for that infant are really important. As we know, the highest time for recidivism is immediately postpartum. So all the smoking cessation efforts that happen during pregnancy, the highest risk to return to smoking is when you have a baby and now you're stressed again about all the new wrinkles in life. And so making sure that we keep those smoking cessation incentives going in the postpartum period and the treatment services for substance use disorder going in the postpartum period are absolutely critical. We don't want to just perpetuate the vicious cycle. And we'll continue through this one too. So transitional Medicaid assistance is a hard one to explain, but I'll just give a very quick overview. So TMA, or transitional Medicaid assistance, is really designed to protect folks from what we call the cliff effect. So when you increase your income, there are suddenly things that you don't qualify for anymore. And that's a tricky place to be in when you're talking about healthcare coverage. And so what we're doing is we're moving TMA, which is the protect from the cliff effect, we're moving it to the end of HIP. So instead of separating the continuum of Medicaid and HIP, is HIP members whose increase in income puts them over the 138% federal poverty limit threshold or level threshold will have coverage through TMA for up to 12 months. And that's really good. That gives individuals a year to figure out what their other coverage options are after they have done all the right stuff and they make just a little bit too much to be in HIP, but really trying to be a series of steps to another set of coverage rather than a cliff. So we're really excited about streamlining the way that we do TMA for our HIP members. The third bucket that we've talked about is the expansion of our Gateway to Work program. We know that in the next 10 years, we're going to have a million jobs to fill, and we don't have that many people. And so we're trying to reach out in this climate that we're enjoying at the moment of this extraordinarily small unemployment rate. It gives us the flexibility to start thinking about how do we help individuals that we haven't been able to help before? How do we think about individuals with disabilities? How do we think about individuals who have been incarcerated that are coming out and looking to get back to work? How do we help individuals with substance use disorder that that wouldn't apply for the jobs that they are wanting to get because they couldn't, quote unquote, pass a drug test? This program isn't that, but it's really part of the larger picture of building a package to help individuals go back to school, go back to work, get training that they might need so that no one is excluded from being part of the economy that we're enjoying. And so Gateway to Work is meant to help Indiana build a healthy workforce. So we're taking all of 2018 to build it. And so starting in 2019, Gateway to Work participation requirements will gradually increase, and we'll level those up, starting with let's try 5 hours a week and see what we can do, and then we'll increase individuals up to 20 hours a week. And we'll help refer members to, and my sneaking suspicion is that the beginning of this program is going to primarily be education and training. That we know, again, that the majority of our HIP members are working already. And so how do we help them go from the job that they have to the job that they want, if that's what they want? Or how do we help individuals who are not working think about their possibility for the future a little bit differently? Is it that they're lacking a high school education or a certificate or that master's degree that they never thought they could get, or the transportation that's kept them disconnected from work because they live in a rural area? How do we think about those things differently and provide that safety net and training opportunities for individuals so that they can do something different? And now this isn't just about work. I think the title or the name of the program, Gateway to Work, might be a little bit of a misnomer. We're really looking for a small population of individuals to connect them to what's next. That might be volunteer work. That might be recognizing this incredible group of people who care for their disabled children or their elderly parents or their next-door neighbor, and really giving them credit for that amazing work that they're already doing. There are a long list of members in HIP that are excluded from Gateway to Work as a condition of eligibility. And we're going to flesh those out over the next couple of months with a next round of road trips and work groups. And I'm looking forward to engagement from not only our stakeholders that we've been talking to, but members of HIP to make sure that we've really got these detailed in a way that work for folks. So students, folks who are already working, those who are pregnant, those who are a primary caregiver of a dependent child under school age or disabled, medically frail, those with a temporary illness, active substance use disorder treatment, former foster children, over 60, recent incarceration of less than 6 months, chronically homeless, or TANF recipients will not be required to participate in Gateway to Work. However, as we've heard from many folks, there are a lot of individuals that are on this list that actually want to be a voluntary member so that they can get those supportive services needed to find their way into the education or employment that they wish. We also have a long list of qualifying activities, and I won't go through all of them, but I hope that you see that we've been really listening to people's voices, and not only our public comment period, but also our road trips, asking what should be the things that we're looking to improve engagement in the community. Things like volunteer work. Those things should count, because what they start is helping individuals see what their contributions to society look like in a really tangible way. So the foundation for the future for this is really what can HIP 2018 for the next 3 years do to build on these successes for the future. And I hope what it does is that it serves as a vehicle for having even stronger partnerships then than we do now. More open dialogue about what we need to do to, again, go back to that beginning of how does increased access drive increased quality and decrease cost. Really start to focus on prevention as a vehicle for a healthier population, having the entire toolkit for substance use disorder within our armamentarium so that we can find our way out of this crisis together. And again, connect us to the quality improvement that we know is possible within the healthcare system in really novel ways. So thank you so much for the opportunity to talk with you about this. And I'd like to tell you about a couple of things that are just on the immediate radar for what we're doing on Friday. So I think today is potentially Wednesday. I've completely lost track of the days this week. So in a couple of days, we are training our stakeholders and navigators from 1:30 to 3 o'clock in the Government Center South Auditorium. and also via live webinar on these particular components of the Healthy Indiana Plan, so that when our navigators and our stakeholders are talking to members, they really feel comfortable about what these things mean, and make it a little bit less daunting for members to think about being a part of HIP. And so if you're interested in the really technical details of how these things are working and how you can be involved, please join our webinar, or certainly join us in person for that additional training. And with that, I will just thank Brian so much for, one, the opportunity to talk with you today, and then two, for being an ongoing partner. Without the Hospital Association and our healthcare community, HIP isn't possible. And so we sit here as grateful partners in this grand experiment that's really doing some pretty incredible stuff and has the eyes of the nation upon it. So thank you.
Well, thank you, Dr. Walpo. Thank you, Allison. Thank you to the entire FSSA team for the incredibly hard work that you put into, not just launching and implementing this innovative and incredibly critical program, but to constantly be good stewards of the program and seek feedback and input. Your office is always open to us for dialogue on all sorts of issues, and opportunities like this are just one example of how much outreach you've done in developing this. And I know you'll probably be doing many more, possibly even today, on this topic. But outside of HIP2, there's a lot of things going on, and so we appreciate your openness on many, many issues. I will open it up for questions. Some of you are logged in and can ask questions through the chat room. I know others are on the phone. I know Andy, hello to our Southern IHA district CEOs. I think Andy and our Southern district members are on the conference call down in Madison today, I believe. So feel free to, operator, if you would go ahead and open up the question line. And for others, if you're still logged in, you can go ahead and enter questions in the chat room. I believe, as Dr. Walpo said, the slides will be available later, so we can make those, send those out later. So operator, go ahead and open it up.
Thank you. The floor is now open for questions. You may submit a question through the web by typing it into the chat box on the lower left-hand side of your screen, or you may ask your question over the phone by pressing *1 on your telephone keypads at this time. Again, ladies and gentlemen, if you do have a question, please submit it via web or press *1 at this time.
If you guys let me off the hook, I won't even know what to do. As on the last slide, my email is public information, and I share it widely, so that if you have specific questions about things that you're seeing in the community, ways that we can improve, we should absolutely keep, or things that we should absolutely pitch, please send those my way. I have an entire mail inbox titled the Complaints Department, and it's one of my favorite things to do is help individuals, and then also at the macro level make our programs better. So feel free to send those along. I have a question that says, how do we register or find info on the webinar Friday? And so, can
you go back to that slide?
Yeah, we'll go back 2 slides, and I will read that aloud for those who are not able to see it. The webinar site is https://indiana.adobeConnect.com/INSSSA.
And if you didn't get it jotted down, I think it'll be in the slides. You can probably click on it.
Mm-hmm.
And we are not requiring any sort of registration or RSVP for the in-person presentation. We have 370 seats in the auditorium, so we can fill them all, and then we can stand in the aisles. So just show up Friday at the State Government Center, and we'll see you there. Thanks, Jim.
Okay, next question. Does the Gateway to Work apply to both traditional Medicaid participants and those considered in the expansion group? Great question, and let me make sure I say that as many times as I possibly can. Gateway to Work is only for Healthy Indiana Plan members. So this is just for our expansion group, not for traditional Medicaid. Allison, did you want to add anything to that?
No, generally that's right, but some Section 1931 parents are included. So it is a little larger than expansion, but I think the most important point in it is not all of Medicaid and certainly not even all of HIP. Yeah. Right. And then in the navigate, I think on Friday is where we'll really drill down on populations and we'll kind of dissect that.
So, for example, the Hoosier Care Connect,
right.
completely exempt,
and our
does not apply, fee-for-service, individuals, and others. So, okay.
So just to give you an idea of scope, I know this wasn't in the question in particular, but when you think about, okay, what are we talking about numbers-wise? When we did our initial screen of how many and who do we think might qualify, that initial number is around 130,000 individuals. However, that's before we go through the granular level of, okay, how many of these individuals are taking care of a kiddo less than 8 or have a child with a disability or are taking care of their elderly parent or have been recently incarcerated. That's not information that we have currently about our HIP member population, and so that number gets potentially significantly smaller as we do all of those screens. And really the Gateway to Work program is meant to be very highly tailored to individual needs. And so we're pretty excited about what that comprehensive assessment for individuals really helps them do.
And Dr. Walter, on that, I think one question that I've had, I think I always want to try to reiterate it when I can. That number, the 130,000, has been in some of the media reports. And as you said, but am I correct that that is an estimate of the number of individuals that, as of now, before further refinements and so forth, it was upon submission sort of the best estimate of those that will be subject to the Gateway to Work program, but not necessarily at all the number that would be expected to be disenrolled as a result of it. And I know that's not what you said, but I think I've heard that number out there a couple times, and I think that's an important distinction.
You bet. And let me clarify that as well and state it again. Our goal, our stated public goal, is that no one is disenrolled because of this program. That's absolutely not the intent of the program. This is meant to be a supportive service for individuals. That the idea that when you get your health care insurance card for the first time that it means more, that our programs actually think about social determinants in a way that haven't been done before. This is a demonstration waiver, so we're trying something different. It is not punitive. It is certainly exactly the opposite of that. So again, our goal and our hope is that because we've given ourselves such a long runway to build this program, that we're not talking about disenrollment. We're actually talking about enrollment plus. We might be getting one more.
Well, thank you for clarifying that. I do think that's one of those things that as the numbers kind of get out there in the report, sometimes they are, the context is lost. Yes, exactly.
Again, we are enjoying the lowest uninsured rate in our state history. We don't have any interest in changing that. In fact, we'd like to make it better.
Well, and I would say that we talked about that briefly just before the webinar, that when we and, as many of our hospitals, and I've had this question, are looking at how we work to, and IHA will be working with the state to try to do this, update the models that we've all had with respect to HIP enrollment and the impact on hospital finances. One of the things that we'll take into account is not only what might be the impact of the Gateway to Work, but also what can we do with the state, the state has always continued, I think, a very robust enrollment campaign. So at the same time we look at the impact of Gateway to Work, we also need to continue the work in the community of signing people up for HIP. We know that there are probably hundreds of thousands maybe that still are eligible that have not yet signed up for the program. So, this is the Gateway to Work program is not the only factor that's going to determine ultimately the net impact or net enrollment that we have a year or 2 years from now. So that's something that while we will bring you more information and work with the state as the contours of the approval are refined into the details of Gateway to Work and other elements of the program, we want to simultaneously continue that work to do outreach and enrollment in the program generally.
Absolutely. And we'll, Jim, our communications director, Jim Gavin, is here, and he, I'm sure on the inside, is beaming and so excited to unveil the next round of what this outreach component from our level will look like. It's hard to keep it a secret because it's pretty cool.
Yeah, people will start to see it fairly soon. I think we're going to be able to overview some of our new member engagement communications on Friday. Essentially, we've done some research in the last year to find out what it is about the Healthy Indiana Plan program after 3 years that might still be confusing to people, not just the members, but the people who surround the members, so the navigators, people in the provider offices. And we've really built some specific communications and new messaging about some of those terms and concepts. The new waiver gave us some of those opportunities, but also just kind of taking a step back and asking people, okay, what is it that confuses you? And we learned quite a bit. So
it's kind of outreach and enrollment 2.0, right? That's what that's good.
And it's beautiful.
Well,
really, really well done. So we're very excited, not just about the content toward the evidence-based practice of what members need, that qualitative feedback, but also just looking at it makes you want to be a HIP member.
All right. Well, again, Dr. Wolfall, thank you so much. We want to be respectful of your time. With no further questions, we'll make the slides available. If you do have questions now or later, send them to us at IHA or Dr. Wolfall.
Thank you all.
Yeah.
Thank you. This does conclude today's webinar. We thank you for your participation. You may disconnect your line at this time and have a great day.